Good morning, Dr.
Good
Stanford. How are you?
morning. How are you doing? I know it's evening for you there, right?
Yes, it is.
Well,
I'm doing
lovely,
great. Thank you.
lovely to see you this morning for me, and good evening to you.
Thank you. Thank you. How are you doing? How's the situation of the pandemic there?
As you may have seen from your news reports, we are not doing that great here with regards
Hmm.
to handling the pandemic. I think
Hmm.
we could be doing significantly better if we just follow what we as doctors say in terms of prevention, in terms of distancing, these types of things that are really quite basic. We're not asking people to do anything really
Hmm.
significant, but as you can see, that has not been the issue here in the United States. And so our
Hmm.
pandemic continues to worsen with regards to COVID-19. I know we're talking about obesity today, but there'll be an overlay in us
Yeah.
looking at, COVID-19 and obesity as we've seen throughout the world. So I'm hoping we can uncover all of those things today.
Oh, me too. Me too.
Yeah,
I'm so excited for this lecture.
absolutely.
So thank you so much for joining us today, Dr. Stanford.
Absolutely.
Before we get started, I'm going to
Yeah.
introduce you to our audience.
Okay, excellent.
And so today we have Dr. Fatima Cody Stanford, and she's a doctor of medicine, of course, and she's an obesity medicine physician and a scientist at Harvard Medical School and Massachusetts General Hospital. She's a fellow of the American Academy of Pediatrics, a fellow of American Heart Association, a fellow of Obesity Society, and also an educator, leader, and a revolutionary in the field of obesity medicine. And if this wasn't enough for you, you can go to her page on the Harvard website, and she has a 113-page resume. So,
It's a lot of reading. If
so
you guys have free time on your hands, you can just have you're like, I don't know what to do. Let me just go and read. That's fine. Otherwise, we could just chat.
so a lot of extensive work that you've done in this field, and I thank you so much for taking the time and joining us today.
Absolutely. It's a delight to be here.
So, coming to our topic, what is obesity and what factors go into making an individual with obesity? So, another thing that I learned from Dr. Stanford was that never ever tag a person as obese.
Mhm.
And that's very important. I
Yep.
mean, I sort of somewhere missed out on that point because everywhere in all research articles I see obese individuals, obese subjects,
Hmm.
obese,
Hmm.
people. So
Hmm.
that's why I use the same. But it's always good to not refer to them as obese individuals, but rather than individuals with obesity, because it's a condition and not just an external a way of looking at someone.
Absolutely. I really want to make that point, and I'm glad that you started us off there. That's if I'm giving any lecture, I always start off with that. It's important, and it's taken a long time for us in the United States, but I would say even across the world for us to recognize obesity for the disease that it is. And so when we talk about it as a disease, that's often like a little bit confusing to people because people think that people made a choice to have this disease of obesity. And it's actually so much more complex than that. So the way, if you think about obesity, it's a chronic, relapsing, remitting, progressive disease that is caused by a variety of factors. It can be caused by genetics, it can be caused by environmental exposures, it can be caused by stress, it can be caused by trauma, it can be caused by the type of bacteria that you have in your gut. I mean, we could keep going. I mean,
Mhm.
that would take up the whole time that we have to just go through all of the
Mhm.
potential reasons why someone may struggle with obesity. But what we do know is that the organ that's most important with regards to controlling one's weight is actually the brain. And it's not the brain in the way that we tell our brain, oh, I'm going to eat well or I'm going to exercise. When patients have obesity, often their signaling with regards to how they eat or how they store, how they exercise is actually controlled by the brain. So the brain is telling them, I get reward from this exercise or I don't. And we're seeing this in pediatric brains. There was a large study that just came out of Yale recently where they looked at the brains of children and saw reward pathways light up in those children that were lean versus those that had obesity with regards to exercise. So just even
Mhm.
then, it's like it's actually in our, not just DNA, it's actually in our organs and how our organs are regulated. And so when I think about that, I think about, okay, when patients have obesity and we know that this is pandemic throughout the world, how do I treat them? What do I do to make it such that this disease is best controlled for them. But I don't say, okay, what works for you and me will work for them. I have a lot of trial and error to figure out this works for them, this doesn't work for them. You know, even within a whole family, I may have a child, I may have parents and grandparents, and the way they all respond to the same therapies may differ drastically, despite the fact that their genetics are pretty well controlled. So I think it's important for us to recognize the heterogeneity, the differences that exist in us in humans, and the differences that really make us unique can also lead to more difficulties with regards to looking at and actually treating the disease. So that's complex. I know that's complex. I see some great friends in here. Someone I haven't seen in a long time, Shamila, shout out to you. But yeah, so that's a key thing.
Okay. And so is it possible for a person with obesity to ever lose the complete weight and keep it off throughout their lives?
Yeah, so I think what you're talking about is changing set point. Okay, so let's frame this concept of set point for those that are like just joining and trying to kind of understand what we're looking at. So set point is this idea that the brain, and particularly is the hypothalamus, you may see this kind of black dot. It looks like I'm Indian right now, but if you were to kind of go through to that, put to the middle of the brain, there's a part of the brain called the hypothalamus. And the hypothalamus is getting signals from all parts of the body. It's getting signals from the fat and from the small intestine, the large intestine, the pancreas, the stomach. It's sending all of these signals to tell my body and your body, and Shamila's body, who just gave me a shout out, how much to eat and how much to store. Okay. And so if it's doing that, then it's receiving signals both externally, it's receiving certain signals internally, and different people will respond to different things. So for you, it may be, oh, I just eat healthy. And what healthy means is like lean protein, whole grains, fruits, vegetables for you. And for you, that may normalize your weight. That may be the signal. That signal alone may be the signal that it needs to change your weight. For 97% of people, that's not usually enough. Okay. So for another group, it may be, okay, well, if I do that, plus I add exercise. Okay, that might work for about 5% of people, you know? So here we still have 95% that what happens is because the brain, once it gets to a certain weight, and I know you guys look in kilos, we look in pounds, but if it gets to a certain weight, let's say that weight is 100 kilos, okay? Once it gets to that, the brain wants to do whatever it can to defend that set point. So think of it like a gas tank, like a car, okay? So a car has a certain size gas tank, right? You can't fill it above. I mean, it'll spill out, right? The oil will spill out, but if it's not full enough, it may not operate quite at its best, right? So once the brain has gotten to, or the body has gotten to 100 kilos and stayed there, the brain is like, okay, that's the gas tank. It wants to fill it. It's going to do whatever it can to make it be that way. You may eat very little, but the brain somehow keeps that gas tank full. So then for those people that are have a much heavier body habitus, then what you might do is you may need to do something more aggressive. You may have to use medications. And when we use medications for weight, they're mostly acting on the brain, right? So if they're acting on the brain, they're temporarily, notice I said temporary is in key, changing set point. The reason why that's important is that if I stop the medicines, what happens? The gas tank goes back to normal. The gas tank goes back to its normal size. Now, if I do something like surgery, like a bariatric surgery, especially for someone that has severe obesity, I'm actually changing the connection between the brain and the gut. The surgeon thinks, okay, I just did the surgery, and oh, it's because it's small, the stomach is smaller, or I skipped part of the stomach, or no, that's not really how it works. It's the signaling that changes. So when you talk to people after surgery, they actually have changes in what their brain wants. So let me explain that. So I have a nurse that works here in our hospital who's a patient of mine. She had severe obesity, and we sent her to bariatric surgery. She hated vegetables before surgery. When I say hated, like hated, despised, like I could not get her to eat vegetables. It was just impossible. And she was in her 50s, so she was very set on her ways. After surgery, she has a craving. Her craving is only for vegetables. She hates that she craves vegetables. She doesn't want to crave vegetables. She has no desire to crave vegetables. She actually hates that she likes salads. She hates that she likes kale. But that's what her body is telling her. So she's not actively making that choice. Her brain has changed such that that choice is being made. Does that make sense? It's very interesting. It's very,
yes.
Yeah. I'm going to let you talk though. If you have a question.
Oh, yeah. No, I can keep listening to you because it's very interesting.
Yeah.
So is overall weight loss more important for individuals with obesity, or do you target like fat loss first and then overall weight? Because there's always
Yeah, I never
a
set actual
confusion.
numbers. I think that's really, really important point I'd like to get across. You know, we use things like body mass index and things of that sort, but body mass index is kind of really great for looking at a whole population, like what's going on in India,
Hmm.
what's going on in the United States. But when you get to an individual level, it's not so much just about your weight and your height. That doesn't tell me like what type of weight you have. Like you said, like is it
Mm-hmm.
mostly fat? Is it water? Like maybe somebody has heart failure and they retain a lot of fluid.
Mm-hmm.
And then I get their heart failure treated and the fluid goes away and their weight goes down 25 pounds. Is that, did their weight just improve magically? So I care about where
Mm-hmm.
that weight's distributed more. So I do set target waist circumference, and you would, I don't know how to
Okay.
do it in centimeters, but in inches, waist for women should be 35 inches or less, and for men, 40 inches or less at the umbilicus, which is at the belly button. Because if
Okay.
you're carrying weight there, right, so fat in the midsection, that leads to
Mm-hmm.
metabolic disease like diabetes
Mm-hmm.
or, complications like fatty liver disease. The liver loves fat, and when fat hangs out in that section, it likes to take it in, kind of like a sponge.
Mm-hmm.
So I care more about that. When I track my with it's not that I don't track weight with patients. Obviously, as an obesity medicine physician, I do pay attention to it, but I track trends. So I look at what was their percent of total body weight loss on X therapy, or the surgeons really like to look at it as excess body weight loss. So I look at it both ways. I just do excess and total,
Mm-hmm.
and then I track over time. So let's say a patient has been my patient for 10 years, and we'll say they've lost, let's say, 70% of their excess body weight and maybe 22% of their total body weight. And then every single time they come, I track the trends. Are we going in the right direction on average, as opposed to like saying, I want you to lose 100 pounds. Because what happens is, let's say they lose 90 pounds.
Mm-hmm.
90 pounds is really great. But if I told them 100, they're going to feel like they always failed, right? But they did extremely
Mm-hmm.
well. They did better than most humans, which is great. So me setting them up in that way at the beginning is setting them up for failure. And that's not what I believe in doing. I believe in supporting people to be the best they can be and not putting some type of false label on what's good, what's good and what's bad. We do look at the trends. We look at their
Mm-hmm.
overall health. We're looking at their lab values. We're looking at their cholesterol. We're looking at their blood sugar. We're looking at whether or not they have diabetes. I mean, we're looking at all those things. We're looking at liver function tests. I'm looking at all of those things in the context of these percentages as opposed to that actual number. Hopefully that helps you understand kind of. Yeah.
Yes, yes, that makes sense. Yeah,
Mm-hmm.
that makes it clear.
Yeah.
Those are some good points you brought up, because in India, to the most part, I would like to be politically correct.
Yeah.
To the most part, when a person goes to a doctor and if they're having obesity, the doctor would first gauge them according to the BMI scale,
Mm-hmm. Mm-hmm.
or even dietitians or nutritionists. They wouldn't care about like how much muscle mass they have, how much fluid they have, or how much fat mass they
It's
have,
just
but they
that.
just like
It's
to
just that. Yeah.
tag them.
Mm-hmm. Mm-hmm.
Yeah, just there.
Mm-hmm.
And then they would resort to extreme methods and tell them, oh, in a couple of weeks you have to lose about 10 pounds or like 8 pounds, whatever the number is. And it goes on and on and on.
Well,
So,
this is not just in India. I'm going to say that throughout most of the United States and most of the world, that would be the case. I actually
mm,
published this paper that came out in the International Journal of Obesity last year, where I looked at the education that medical students, resident physicians, and fellow physicians receive with regards to obesity in every country in the world. So I looked at India, I looked at Switzerland, I looked at what they're doing here in the
mm,
US, and no country does a good job of educating doctors about obesity,
mm,
which is
mm,
problematic, right? So if this is the largest chronic disease in the world and no country does a good job of teaching anyone about obesity, then we're failing. To me, I think we're failing our patients, because if a patient comes in with
mhm,
me and I don't know how to treat the thing that I'm most likely to see, that's kind of a problem. So one of the things that I've really been kind of championing and really kind of speaking out against is the act that we don't educate doctors. And so then you go to, like you said, you go to see your doctor and the doctor's like, okay, you got to lose 20 pounds and this time or whatever, X
mm,
number of kilos, et cetera, et cetera. That's problematic. And it sets up a bad relationship with the doctor and the patient, or the
mhm,
dietitian and the patient. they decide, hey, I'm just not going back because I go and then I try these things and I'm not accepted. And that's problematic. That's just not how you do things. People don't feel valued. They feel like they're not supported. If somebody were to come in with
Mhm.
diabetes and it's immediately, okay, you got to lose 20 pounds, but not treat the diabetes, in any country,
Mhm.
that would be seen as really like a bad thing, that you didn't do a good job for the patient. Or if, let's say somebody came in with cancer. Let's say their cancer
Mhm.
came from maybe, inadequate lifestyle choices. Maybe they were a smoker, or maybe they never exercised, or maybe they only ate, processed foods. We don't say, okay, because you did those things, we're not going to treat your cancer. We treat the cancer and then we try to introduce those things. And so that's really
Mhm.
how we have to think about obesity. We have to think of it as a disease that leads to all of the things I just mentioned. It can lead to most
Mhm.
types of cancer. It can lead to diabetes. It can lead to all of these things. And if we just treat it that, we could often eliminate a lot of these things. I take a significant pride and joy when I'm working with patients and I'm able to take off things off their list of problems. Sometimes as a
Mhm.
doctor that has to bill, right? I have to bill and make money. I remove all of the problems. And so I have to come up with, okay, how am I going to get paid to see this patient? So I have to say history of obesity, history of
Mhm.
diabetes, history of high cholesterol. I have to say history, like I can at least bill for the fact that they had a history of it, because a lot of times
Mhm.
a lot of them go away. And so I don't have anything left, which is, what other disease can we treat where I can like treat that and then I can also eliminate all these other things? If I'm treating diabetes, I just treat
Mhm.
diabetes. If I'm treating asthma, I'm treating asthma. If I'm treating heart disease, I'm treating heart disease. But I'm not treating something that's leading to other changes. I mean, that's what makes my work so gratifying is this idea
Mhm.
that I have to actually come, begin to think, well, wait a minute, they don't have any problems anymore. I don't know what to, I mean, I just can't, I keep up with them, because the body, like I said,
Mhm.
it always wants to kind of creep back to where it was, and so it's chronic. But
Mhm.
the degree or severity of what they have may change over time, and that means that we're doing well with our treatment, and that varies from person to person, right? So
Mhm. Okay.
yeah,
And so you may have observed even pediatric obesity or childhood
I
obesity.
do.
And how different is treating a pediatric obesity than adulthood obesity?
So it's a very good question. So I do see kids and adults. We start seeing here children at the age of 2. Tomorrow on my schedule, I do have a 3-year-old. My first patient of the day is a brand new patient. When you're seeing kids present that early with obesity, you know that it's definitely not something the kid did to themselves, right? They likely had parents that had obesity, right? So it's important to note that weight is more heritable than height, which means that if you have parents that have obesity, the likelihood that you
Hmm.
yourself will have obesity will be on the order of somewhere between 50 and 85%. That's even if you do
Wow.
everything perfectly. So
Hmm.
when a 3-year-old comes into me that has had very short life, or a 2-year-old, that means they're already starting, like, so that we plot them on growth charts. They're already starting way up here, but they're supposed to be here, and often they'll
Hmm.
follow their curve. So their brain has already told them this is where they're supposed to be. But if you look at mom and dad, or look at their grandparents, because it can also skip a generation, kind of go there, you're like, okay,
Hmm.
well, this kid is definitely from this family. Um, and so it's important for us to note. I see a question that's coming in. I'll talk about hormones and obesity. It's important for us
Yes.
to note that that individual may have a genetic component. So I may do genetic screening to especially if they have really early onset severe obesity.
Hmm.
I have a harder time, obviously at that age, really, really young ages, I can't use medications. I can't really use surgery, right? But as they get into, let's say, adolescence, can begin to use medication. I can begin to use surgery. So the older they get, the more I'm able to do. But I can tell you that sometimes in those
Hmm.
earlier years, since it's not just their behavior, right? It's not their behavior at 2
Hmm.
that led them already to have obesity. It's something that they got from someone else often. And so that,
Hmm.
I can tell you, that presents some challenges, and it's a bit more frustrating than an adult coming in where I'm able to kind of immediately do something without
Hmm.
limitations in many situations. Um, so that's important. Now, do you mind if I entertain this question about hormones and obesity? That's a really complex thing. We can do an hour talking about hormones, but there's different hormones in our body that regulate weight, and many of them control our appetite. So they can either cause us to have a increased appetite, what we call orexigenic effect on our bodies, or they can have an anorexigenic. Anorexigenic means that we get full quickly. So one of the most important hormones, for example, is ghrelin. So ghrelin is a hormone that's in the stomach, but it's also in the hypothalamus, going back to that part of the brain again. And it tells our body that we are hungry. If you have high ghrelin levels, I mean, I would need to be eating this whole show. Like, I mean, I'd be like, oh my gosh, I got to eat. I got to, you know, and it's not that I'm telling myself to eat, or it's not like, it literally is my brain and my gut are telling me I need to eat. And because I am getting that signal, then what do I typically do? I go and eat. And I can try temporarily. And this is what happens when people try lifestyle and may lose weight acutely, but then regain it. The body gets very angry when you don't listen to what it's telling you to do. So if you're thirsty, right, and you don't drink, then you start feeling weak and dizzy and all these types of things, right? So you go and drink water or whatever it is that, you know, that you have. Maybe you drink tea, whatever it is, you go and do those things. When your brain tells you to eat and you don't eat, I mean, you could stop eating, but then how long can you ignore that signal when the brain is telling you to do that? Maybe for a short period of time, maybe you can do it for a month. Like, you did that diet. That's why I don't believe in diets, right? Because it has to be sustained over a long term. So ghrelin is a hormone, a powerful hormone that tells our brain it's time to eat. Now, let's switch to something else. Like if we're looking at something like cholecystokinin, it's a hormone, a CCK, we'll just call it that. It actually tells our body that if we have high levels of it, it tells us we get full really quickly. So these are the people that you see them sit down and they have a plate. Let's say the plate's really tiny, like this, and they eat one morsel and they're like, I'm so full. And you're like, there's no way they're full. But maybe they have high levels of CCK and they just get full super quickly. And it's not that they tried to get full quickly, their body told them. So there's different hormones in our bodies that tell us to get full or tell us to get hungry. And there's so many, I mean, we can't go over all of them, but these are a few examples of the ones that may cause you to eat, and then the ones that may cause you to not eat, basically.
Thank you so much for addressing that question.
Absolutely.
And since we are talking about fitness as well,
yes,
which exercise routine? Yeah. I also see on your profile that you love dancing.
I love dancing. I'm trained in ballet, jazz, West African, hip hop, and point. I don't dance I dance for workouts, but I don't really dance like I used to dance back in the day when I was, you know, closer to the professional level. That was 20 plus years ago. I'm older than I look. So yeah, so I do love fitness. So let's talk about fitness. This is one of my favorite topics.
So what components of fitness are important in treating obesity? For example, resistance training or cardiovascular training or whatever.
So I think
come across.
Yeah, no. So I really think I need to get a major important point across when we look at exercise or physical activity and the role it plays in weight regulation. The message that we typically sell is wrong. Okay, so let me explain what that means. A lot of people go and join a gym or they start working out to lose weight, right? On average, most people don't lose very much weight. Their weight may stay stable. So let's go back to that 100 kilo person, which sounds like a large number, but not for patients that I see. And they start working out and they get frustrated. But let's say over time, let's say they started at 88 kilos and then over time they got up to 100. So they gradually creep that way over, let's say 10 years. Okay. So let's just say they gained a little bit every year or so. Physical activity would help to keep them, even if they didn't like where they started. Let's say 88 was not where they wanted to be. Maybe they wanted to be at 70 or 65, whatever. It would help stabilize them and keep them there instead of them rising to the 100 that they're now at. So the message we should be selling about physical activity, whether it's cardio, whether it's resistance, where it's a combination thereof, I do like to encourage both, is that on average, it helps keep us stable. Now, are there certain people that may lose because they introduce activity and they were completely sedentary before? Absolutely. There are those people. But for many people, they get very frustrated because they go and join the gym or they start bicycling or whatever it is that they started doing. And then they're like, but I didn't lose any weight. And so then what happens is they stop doing the exercise because they're like, what's the point of that? Now, we know exercise has a lot of other good benefits. You know, it improves our heart health, improves our mood, it decreases depression. Just all kinds of fabulous things, right? So I always tell my patients that the physical activity is not just about that number on the scale that we become so fixated on. It's about improving your overall health, because even if, let's say, you stay at that 100 kilos and now you're exercising every day, those other numbers I look at, like your cholesterol, your blood sugar, your, you know, all those types of things, they can improve dramatically, even if the weight stays the same. So it's important to say that that one metric, that number on the scale, is not the end all be all. So I think you kind of hear that kind of being the recurring theme that I'm saying. It's not just the number on the scale. It's multiple things that play a role. Number is one of them, but one of many things that I look at.
Okay,
Yeah.
that's great. And so as fitness professionals and nutrition professionals, how can doctors who treat obesity, fitness trainers, and nutritionists work together and treat obesity as a whole?
So that's great. Actually, I just see one of my docs that just joined, who's at our center. She's an obesity medicine physician. Dr. Vera has just joined. So the way that we do things here is we do have a multidisciplinary team where we have a doctor that does the medical kind of side of things. Hello, my dear. And then we have a dietitian that takes care of that part of the puzzle. So the dietitians are well trained to be able to guide and tailor one's diet to their cultural things. So for example, in India, you guys may be eating, you know, what is it, some fabulous things that I know that you guys like. So lentils is a huge thing in India. You know, like there's certain key things, right? So if I were to propose to you a diet from southern Black community in the United States, lentils wouldn't be part of that diet. So I need to tailor it to fit what you like, or what would be part of your things that you might eat. You know, maybe you like eggplant. You know, there's certain key things that are kind of heavy in, you know, an Indian diet. So that's something that we need to think about, is tailoring it. And so the dietitian is able to do that work, right? Spend that time working with, you know, and I think they call it a client, as a patient, depends on how you're looking at it, to fit that. Now, the physical activity piece of the puzzle. So someone like you, okay, I need to find that patient's soulmate workout. So I hate skiing. Let me tell you, if you told me that the only activity that I could do was skiing, I would be very sedentary, because I don't like to ski. I hate it. I love a lot of activity. I love weightlifting. I love cardio training. I love HIIT interval training. I love dance. I love all these different things. And so obviously I need to really stay more there, because those are things I enjoy doing. And if you tell me right now, stop this interview and go do that, I'd be like, okay, I'm ready. I mean, I'd have to not look like this, right? I have to pull my hair back and all that, but you know what I'm saying? You get what I'm saying. So the whole point is that fitness professional can work and tailor the activity to that person. What if someone they've had severe knee pain, and, you know, that's something that makes them not work out. So then maybe for them, you shift them to doing maybe swimming or things in the, you know, pool, or you shift them to doing things like a recumbent bicycle or something like that, you know, things that won't put pressure on the knees. And so you see how, like, each person has their own role. Now, if the doctor is trying to do all of that, they probably won't be able to focus on some of the medical pieces that are really important. So it's nice to have those different people, right, doing the things that they do well. Like if you're a fitness person, do fitness well, but for everyone on the team to not sell the message that they failed if something didn't work, or if the weight didn't move. It's about finding the right recipe for that person, right? So that's kind of how I think about it.
I completely agree with that, because as long as they're doing something, it's still progress.
It's still progress. And then you want them to sustain it over time, right? Like you don't want them to start and stop. Now they may be one of those people like me that I get bored very quickly. So maybe they're doing this and that's boring. Now let's move on to the next thing and the next thing. And so for that kind of person that gets bored very quickly, you just keep changing it up for them. There's some people that they just like to do that run, and maybe they go do a 5K every morning, and that's just what they like to do. And if you ask them to do anything else, they're like very discouraged. Yeah, you may try to introduce some other things. Maybe they need some core training. Maybe they need some Pilates or yoga introduced. But you have to find like what they like, and try to get them to find things that they enjoy that they'll do indefinitely, right? Because until we're gone from this earth, we should be doing things. And what we're doing, you know, in our 20s, 30s, 40s may differ drastically from what we're doing in our 70s, 80s, 90s, for example, you know?
For sure.
So, and although when in my workout classes, a lot of people in their late 70s do still come. I don't know if they do it slightly differently than I would do it, but they're still doing that activity.
Great. And so this brings me to the next topic,
Okay.
which is the article that I read that you just wrote for Harvard Health Beat newsletter.
Mm-hmm.
And it was titled "Stop Counting Calories."
Stop it. Just stop
Which,
it. Yes. And
yes.
now we can talk about
So,
that.
so are calories in, calories out the only way of looking at,
That's actually the wrong way of
anything?
thinking. You should never, ever,
Okay.
ever look at it that way. So if it were that simple, I wouldn't have my job. I wouldn't be talking to you today because I'd just be able to give you a calculator and say, here's the just calculate your deficit and everything's fine. That's completely the wrong way to do it. What we do know is that we're not just a vessel that's the exact same. So if I had a cup, I don't have a cup right here, but let's say I have a cup. That cup you put in is going to always be a certain amount, then you take out a certain amount. It doesn't really respond to its environment. It's just that solid cup with no really differences. The problem is that when we put things in or take things out of us, we all respond differently. So I might, let's say I were, I don't want to pick something I would eat. I don't know. Let's not use me. Let's say someone eats a donut, and they store and hold on to that entire donut, and then you eat the donut, and then your body kind of holds on to like a quarter of it. Did you do something better than they did, or did your body just respond to it differently? It's the same number of calories, right? Let's say that donut is 200 calories. It didn't change, right? Like that didn't change for you or for them, but how their body responded based upon their gas tank, based upon those signals differs. So I never, and my patients can tell you, ever track calories. It doesn't mean anything to me. What means something to me more is how processed their diet is. So if they're eating all fried foods, all things that don't look like they look in nature, then okay, then we have a problem. That's important to me. But looking and microscopically looking at the number of calories won't necessarily shift weight significantly different than someone else. It's more about the quality of the diet, processed versus not processed. And studies after study really continue to prove that, it's not just a calorie deficit that we're thinking about. Often when you're eating high quality food, which means like those lean proteins, whole grains, fruits, vegetables that we talked about, you do get full quicker because it's just denser. So if I were to give you mixed greens and then I throw in some tomatoes and onions and peppers and, mushrooms, and I gave you a whole bowl. Let's say I gave you a whole bowl like this. You guys can see that whole bowl. That whole bowl, I mean, it may be only like 400 calories, but I could technically feed you for 3 meals off of that because you would get so full because it's just so much volume, meaning like lots of water density, right? So it expands in your stomach. You feel, wow, I feel full, So that's you want to pay more attention to that than you want to pay attention to like, oh, you ate 35 calories of this. And that kind of microscopic thing also stresses you out. We know stress leads to inflammation. It leads to more fat deposition in your stomach. So why stress yourself? I mean, we already have enough stress in the world. Why stress yourself out about doing something like that actually doesn't, over the long term, really lend itself to good quality of life? And it also deviates from how the body stores differently for individuals.
Great.
Yeah.
And so since meditation came from India years ago, has it helped any of your patients or anybody with obesity?
This is very funny that you're bringing this up because I gave an hour-long lecture for the Harvard Benson Henry Institute on just this past Friday on stress and obesity.
Okay.
And people don't realize how much of a contributor stress is to obesity, because when stress happens, however one experiences stress, what may be stressful to me may not be stressful to you or vice versa. But if that person feels sometimes they don't always feel it, but that increases inflammation in the body. And how do we mitigate that? Going back to what your question is looking at things like meditation may be helpful. Now, let me tell you who does not do meditation well. That would be me. I just don't do it well. I think that certain people, it's sometimes, it takes a lot of practice. Maybe I just need to practice more. It's not something, if I usually like to do things that I'm good at, and if I'm not good at them immediately, then I just don't do it. So thankfully I'm good at quite a few things, so that helps. But yeah, so meditation though is a way to help mitigate stress, right? Same as yoga, which, has some significant origins in India. That's not also something I do well because it's boring to me. But anyway, so But anyway, let's going back to these things. These things are ways that can mitigate stress for me as a Christian. Prayer can be very calming for me.
Hmm.
And so it's about finding things that work. But meditation can be one of those things that can help many people. And maybe someone like you could encourage someone like me, you have a lot of stress, you have a lot of work going on. Maybe we can get you to meditate just 10 minutes, 10 minutes. That's freaking hard for me. That's so 5 minutes, start 5 minutes. I don't know. But you can gradually introduce that into your regimen. And if you gradually introduce that, that could help bring stress down, and that could help regulate weight with changing nothing about calories. Going back to why the calories thing is not so great, right? All I did was
Hmm.
change, well, that's a big thing, to change someone's stress level, and they start noticing, wow, I'm losing weight. I don't know what's going on. And then they were like, and then I'll listen to them and I'm like, oh, your stress is improved. Maybe they got a better job. Maybe their family or relationships improved in some way, form, or fashion. And then without us doing anything differently with regards to how they're
Hmm.
eating or how they're exercising, they start to lose weight. And so hugely important. Using whatever modality or multiple modalities help reduce stress, I think, is important.
Great. I completely agree. It
Yeah,
doesn't have to be only Indian meditation. It can
right,
be any spiritual
right.
healing that
What the person
is
does.
associated to your religion or belief.
Yeah, absolutely. And and like as I said, this comes to like tailoring it and not using a cookie cutter
Hmm.
approach, right? Like what works for you, what may
Hmm.
not work for me. And so I have to listen to my patients because I don't know how they're going to respond. If they tell me, "Oh, I really don't want to do that, doc," then I can't push. Then that creates a bad dynamic between the two of us.
Hmm.
And it just doesn't lend itself to good outcomes.
And if you were to give a small guide
Hmm.
um, to individuals with obesity who
Hmm.
are unaware of how to treat it,
Hmm.
how would you go about it?
Well, I've written a whole book for that, so I would just go and
Oh
buy
yeah,
my book.
yeah.
um, oh, there's one of my favorite people, one of my parents' friends. Charlie has joined us. Good to see you, Charlie, this morning. Um, so I wrote a book called Facing Overweight and Obesity. It's a complete guide for children and adults. It came
Hmm.
out of Mass General Hospital, so I'm the main or the first author listed on the book. It's available, on Amazon. And
Hmm.
so my goal with that book and writing that book was to teach people about obesity, to say, um, okay, this is this disease. These are all of the things that could contribute. Let's look at how media plays a role. Let's look at things like stigma and bias, how it plays a role. Oh, wait a minute. These are all of the diseases that may be associated. It explains in pretty good detail all of these issues. So I think it's a great starting point, and that was the reason why I took the time to write it. It was
Hmm.
because I realized a lot of times patients just have no idea, but also docs have no idea. So a lot of doctors do
Hmm.
refer to it, and they refer to it because they feel that they don't know things. And so this really kind of breaks it down. There are some things that are a little bit complex when we're talking about some of the diseases associated with obesity that may feel a little bit hard to or difficult. And it shows you how difficult this disease is. It's not easy.
Hmm.
So, yeah.
Okay. Yeah, I was going to mention that, and you've written another book as well, which is behavioral science,
Oh,
I
that's
suppose.
for medical students. Yeah, that's only, yeah. So if you,
Okay.
that's for people studying, I wrote that in med school. So a little while ago. That is a book for people studying for the what we call the USMLE Step 1. So USMLE is United
Hmm.
States Medical Licensing Exam. If they're studying for that step exam, there is a large behavioral sciences component. And so that book is to really prep them for that section. So that's not more of a,
Yeah.
I wouldn't, unless you guys just want to just buy it, but I wouldn't say that, if you, unless you're a med student, it won't really be as helpful to you. Whereas the other book is written with everybody in mind.
Hmm.
Yeah.
Yeah, and I was just checking the other book on Amazon India,
Hmm.
and it isn't available in hardcover form, but it is available on Kindle version.
Well, that's great.
So
So I knew that we have a
yeah,
Kindle version. So for those of you guys in India, Kindle version is all yours. It's the exact same text. We didn't modify anything for the Kindle format.
great. And Dr. Stanford, would you like to add anything else to our conversation? Because those were all the questions. In fact, I asked you a few more questions also.
I think the key thing is that if you either have family or friends, or if you're a healthcare professional treating patients with obesity, to be compassionate and to have empathy. Often people just want to have someone that can listen and that can empathize with them regarding their disease. And instead of just accusing them of doing something wrong, actually help them develop actionable solutions that are long-term and sustainable. When you do that, you change the dynamic with you and that individual, whether it's a personal connection or whether it's a professional connection. And for maybe the first time in their entire life, they began to believe that, hey, I can begin to address this disease of obesity. I have help. I have fitness professionals like exercise physiologists like yourself. I have doctors that are there willing to listen, willing to take a chance to tackle this really complex disease. There are times when I'm working with patients where I feel like, gosh, what can I do next? And I just keep trying. I can't give up. You know, they came to me for that expertise, and usually I'm able to do things, you know, I know kind of quickly what I'm supposed to do, but their body may respond very differently than what I would anticipate. And if that's the case, I have to keep being that ally. I have to keep being that support. And I always tell my patients, yes, I'm the doctor, but think of me as like the coach, right? So if you don't show up for the game, you're the star player, we can't play. You know, I need you because you, meaning the patient, if the patient, what a lot of what I tell them or the team is telling them, if they're working with a dietitian, that happens not when they're with me, right? They have a short period of time they're spending in a visit with me. And then I may see them later. Hi, Emma. That's Emma from Croatia. We have all kinds of countries in here. Hi, Emma. Emma's my little, I call her a little sister. So when we look at that, it's important for us to recognize that, you know, this disease is complex. It affects everyone differently. And we have to have those people there to make sure that we're doing the best thing to help them. And just to not give up and to recognize that things are continuing to evolve. What's really exciting about the field of obesity medicine is that unlike other fields, which are kind of steady, hi dear, she says hi big sister. What we see is that a lot of the fields are very steady. This is, we're constantly learning new things. For example, we talked about the bacteria in the gut. What we do know is that for people that are lean versus those that have obesity, they have different bacteria in the gut. You might be like, well, why does that matter? What happens is if we take the gut bacteria out of lean individuals and put it in those that have obesity, we see weight changes with nothing else. That's brilliant. Who would have thought of that? It's literally your stool. I take the stool out of you and put it in somewhere else, and that changes your weight status. So I think, you know, we're exploring more things. We need to be thoughtful about the language we use. Like we said, patients with obesity, that's going to be extremely important. We can do it. We just have to try harder. So we can't accept any we can't accept anything else. We wouldn't do it for ourselves. We can't do it for our patients. We can't do it for our friends and family that struggle. And sometimes it takes people that have struggled with this disease quite a long time to begin to accept that, you know, they do indeed have this disease and that disease warrants treatment. So some people that may have the strongest issue with it, meaning the most severe obesity, may be in some denial surrounding that. And it's okay. And we have to just kind of help get them along, right? Get them to understand that, okay, this is a disease, you have it, we can treat it, but we have to do this together. So that's kind of how I would conclude.
Well, Dr. Stanford, thank you so much for taking the time and addressing us today.
It's been my delight.
Please keep doing the good work. Yes, and you also have a compliment here, Dr. Stanford. You're an inspiration to so many women. I absolutely love your body of work.
Oh, thank you so much. That was so sweet. Whoever said that, I love you. Thank you so much. That's a good way to continue. Let me tell you, my night, I have lectures that go until 9 p.m. my time. So this will be all day. So you guys are getting me in the fresher part of my day. So thanks for that encouragement.
Thank you so much for the time, and please keep doing the good work that you're doing.
Absolutely. Have a fabulous day, okay?
Thank you so much.
Okay, bye-bye.